Okay, cool. Good afternoon, everyone. Today we'll be discussing the approach to the aggressive patient. It is myself, Emily Rose Miller, Dr. Melanie Codling, and Dr. Zanda Bio. So we're first going to start off by sharing a clip from Grey's Anatomy, where we can witness an aggressive patient, but I'm sure we have all encountered this at one point or another.
No. To lay down. You shouldn't be up. Let's get back on the bed, Lou.
Okay, so first let's start off with some definitions. What can start off as agitation can progress to aggression and then eventually to violence. So agitation is increased motor or verbal activity with subjective feelings of tension. Aggression is any verbal, non-verbal, or physical behavior that is threatening to harm others or property. And violence is behavior that involves the use of physical force with the intention of causing harm to people or damage to property. So risk factors are what could give us a sort of warning of a possible aggressive patient. Historical risk factors would be patients with a history of violent behavior or loss of control. Dispositional risk factors are male patients more likely of a young age. Contextual risk factors such as family influence, for example, sorry, I just saw the message from Pro. Contextual risk factors such as family influence, for example, exposure to conflict or violence, childhood experiences of aggression or violence, history of abuse, peer influence, access to instruments of violence, substance abuse, and intoxication. Psychiatric disorders that are likely to cause aggressive behavior are psychotic disorders, mood disturbances, intellectual disability, personality disorders or traits, for example, antisocial or substance use disorder. And then psychological risk factors are chronic anger, hostility or resentment, and a high degree or intent to do harm. So in our context, the most prevalent risk factors are substance use, either intoxication, substance-induced psychosis, or withdrawal states, prior aggression or a history of violence, and learned aggressive or violent behavior from a young age. So substance abuse is a seriously large risk factor, and I'm sure anyone that has done their month in ED already can agree to this. So just some statistics. Approximately 3.7% of the country's population uses cannabis, followed by cocaine, 1%, and amphetamines, 1%. Less common drugs are opioids, opiates, and ecstasy-type drugs. Whereas between 7.5 and 31.5% of South Africans have an alcohol problem. So this graph is just to show this graph is just to show the percentage of positive test results for drugs and people that have committed violent offenses or property offenses. So of note, more than 40% of people that committed violent offenses did test positive for cannabis use. Unfortunately, this graph doesn't mention alcohol, but of interest, during the alcohol ban in March and April 2020, there was a more than 60% decrease in murders, rape, domestic violence, and robbery with aggravating circumstances. Okay, next slide, please. Okay, so next we'll look at some causes of aggression. Remember that aggression is not a psychiatric diagnosis, but rather a manifestation of medical or psychiatric disturbance. So psychological causes could be instinctive, according to philosophers Freud and Lawrence. Freud believed that aggression was directing self-destructive death instincts away from self and toward others. Lawrence believed that all humans share fighting instincts with other humans and other creatures. It could also be learned or social based on past experiences or external situational factors. Social causes could be frustration, which is associated with the perception that the patient's frustration is being ignored, especially by the family or by healthcare providers. Direct provocation, television violence, or social media social medias, particularly in terms of sexual violence. So there seems to be thinking that violent video games would increase aggressive behavior, but studies have shown that rather a competitive video game and losing in a competitive video game can increase aggressive affect, but a violent video game does not have any impact on aggressive affect. It's just a funny picture. Okay, and then of course there are medical causes. I'm sure everyone is familiar with the abbreviation DIMTOP for causes of delirium. Some factors to alert of possible medical causes are patients that are older than 40, reporting visual, tactile, or olfactory hallucinations or illusions, and a patient that is disorientated. Okay, so going into DIMTOP, D stands for drugs, which could be drugs of abuse, such as alcohol, cannabis, amphetamines, or cocaine, drug withdrawal states, or prescription and non-prescription medication. Common medications that cause delirium are steroids, anticholinergics, and of note in our population, antiretrovirals. I is for infections, so sepsis, systemic infections, particularly HIV or syphilis, and CNS infections such as meningitis or encephalitis, as well as your pneumonias or UTI. I is for ictal, epileptic seizures or other CNS conditions such as cerebrovascular accidents. M is for metabolic derangements. So this could be electrolyte abnormalities such as hypo or hypernatremia, endocrine disorders like hypo or hypothyroidism, acid-base disturbances, particularly acidosis, hypo or hyperglycemia, or nutritional deficiencies such as seen in Wernicke's encephalopathy, vitamin B12 deficiency, or folate deficiency. T is for trauma, especially head injury, toxicity from poisons, or a tumor. O is for organ failure, liver, renal, cardiac, or pulmonary or hematological disease, or oxygen deficiencies. And then P is for psychiatric disorders. So we're including this in medical causes because it may present with a clinical picture of delirium or an acute confusional state. And so medical causes must first be excluded in all such cases.
Okay, so the clinical protocols to keep in mind when dealing with an aggressive patient is to ensure a patient is first medically stable, apply resus principles as necessary, identify a place to manage patients away from the crowds. Before approaching the patient, gather as much information about the patient and the situation leading up to the current state. This includes psychiatric history, substance use history, and a medical history. Triage and prioritize possible at-risk cases. Avoid patients waiting long periods in uncomfortable situations. Have regular M&M meetings to discuss and improve, and train staff regularly. Then finding the underlying cause for the aggression. A careful physical examination, psychiatric evaluation, and side-room investigations should indicate whether the patient is delirious or psychiatrically ill. Side-room investigations that can be used include urine dipsticks, urine toxicology screen, blood gas for electrolytes and acid-base disturbances, blood glucose, and infective markers. Then, if the patient is delirious, it becomes a medical emergency, which the cause needs to be sought and treated, and such patients should be transferred to a medical unit. So just to help differentiate between delirium and psychotic illness clinically, delirium has more of a sudden onset, whereas a psychotic illness is gradual, days to weeks. The course of delirium is usually fluctuating and worse at night, whereas a psychotic illness is continuous. Consciousness is usually impaired with delirium, and a psychotic illness patients are alert and awake usually. Orientation with delirium is impaired in all spheres, whereas a psychotic illness usually preserved to person and place. The hallucinations of delirium are usually visual, whereas psychotic illness mainly auditory. Illusions may be present with delirium, but very rare with psychotic illness. And then involuntary movements, usually coarse tremor with delirium and usually none with psychotic illness. So then the management of the aggressive patient. So each hospital should have a plan in place in the event of an aggressive patient, with doctors, nurses, and security personnel informed of their roles. So step 1 is to ensure that the environment is secure. Step 2 is de-escalation. And step 3 is restraints if de-escalation fails. And this can come in the form of chemical, physical, and environmental restraints. So step 1, to ensure the environment is secure. Ensure that you have adequate support. There is safety in numbers. Security and staff must be readily available when dealing with a patient displaying aggressive or dangerous behavior. Potential weapons must be kept out of reach of the patient. If a weapon is present, the safety of oneself, staff, and other patients takes priority. Alert security guards and the SAPS to take over the situation immediately. Then clinicians must have access to an exit, and an alarm or bell should be available to the doctor. So step 2 is de-escalation. Always try to diffuse the situation using the least amount of physical contact. The most preferable method of resolution is always personal and empathetic dialogue. Approach patients with caution, avoid abrupt movements and vulnerable positions, such as turning one's back to the patient. Introduce yourself and involve parties. Speak clearly, slowly, and firmly. Reassure the patient of your intention. Negotiate and collaborate rather than maintain authority and control. Grant reasonable requests. It could help diffuse the situation. However, do not offer cigarettes or other items that could be used to harm you or others. Do not threaten or humiliate the patient, and give up sooner rather than later. So get out or get help. So if de-escalation fails and the patient is still displaying aggressive and harmful behavior, using restraints is the next step. Restraints can be classified into 3 main categories: either chemical restraints, also known as medications used for sedation; physical restraints, which are appliances used to limit free physical movement of the patient and can't be removed from a patient. This is jackets or hand restraints. And then environmental restraints, such as seclusion rooms. These create a barrier to a patient's free movement and confines the patient to a certain area. So chemical restraints, such as sedation, the main sedative drugs that we use is benzodiazepines and antipsychotics. Benzodiazepines used can be lorazepam, 1 to 4 milligram, IM, IV, or per os. Response time is 30 minutes. Diazepam, 10 to 20 milligrams IV, and a response is quicker in 10 minutes. And then other benzodiazepines that can be used are clonazepam, which is also known as Rivotril, 0.5 to 2 milligram IM per os or IV. And then it's also important to note that one should only use oral treatment if the patient is not an immediate threat to him or herself or the environment. So then some safety concerns when using benzodiazepines. So avoid them as much as possible in a delirious patient, as it can complicate further evaluation of the patient. Then benzodiazepines are safer than antipsychotics, but take care that they do not accumulate because a lot of them have long half-lives. And they can also cause respiratory depression. So it's important to monitor the vitals carefully when used. And then never combine lorazepam or diazepam with other drugs in the same syringe. Never use the intramuscular route for diazepam because absorption is unpredictable and therefore dangerous. And then the maximum rate of administration of IV diazepam is 2 milligram per minute, and IV lorazepam should be administered over 2 to 3 minutes. Then antipsychotics can also be used for sedation. We use haloperidol, 5 to 10 milligrams per os or IM, and then you should wait 30 minutes for a good response. Antipsychotics can either be added to the benzodiazepines or used separately. And then safety concerns is extrapyramidal side effects. So if you administer this medication and the patient still remains unmanageable, still needs physical restraints up to the waiting period for the onset of action, then the above mentioned doses may be repeated. Follow the repeat doses by a further waiting period as described above, and if still no response, repeat the treatment for a third time. So here is just a summary of the max doses that one shouldn't exceed when sedating patients. Diazepam 60 milligrams in total, lorazepam 4 milligram, clonazepam 4 milligram, and haloperidol 60 milligram. So contact a consultant in cases where the necessary improvement has not occurred despite treatment with the above mentioned medications. And then monitoring with sedatives. So the vitals should be monitored every 15 minutes for the first hour, then hourly until the patient is moving around. Ensure that an open airway is maintained by positioning the patient correctly. Then monitor for side effects mentioned before. And then if a proper examination couldn't be done earlier, it can be done now when the patient is sedated. So just a summary of the pharmacokinetics and dynamics of these sedatives. So just to summarize, diazepam is faster acting and it also has a much longer half-life, so it accumulates. And then lorazepam is also fast acting, but not as rapidly as diazepam, and has a shorter duration of action. Okay, I'll now hand over to Linda, who will do physical restraints.
So physical restraints. So this is usually used for the protection of patients and others when medication and verbal therapies are insufficient to control potentially violent patients, or it is used to aid administering medication if a patient is uncooperative. So 5 trained staff members should be used, 1 for each limb and 1 as the lead. And ideally 6 people so that the 6th person can actually administer the medication. The team leader attempts to contain the behavior and gain cooperation by speaking firmly and respectfully to the patient. It is also important to inform the patient of impending restraint and explain that it is for their own safety and no harm will come to him or her. The patient must always be informed about each step of the procedure. Mechanical restraints must be used for as short a time as possible under continuous monitoring, so meaning that we have to take half-hourly notes. It is also important to prevent aspiration, decreased limb perfusion, as well as nerve compression injury during this time. And it is also important to not release the patient until the medication has taken effect. In terms of seclusion rooms, these can be used if available at the facility to remove the aggressive patient from an area where he or she is likely to cause harm and confine he or she to a certain area. Patients generally prefer seclusion rooms over physical restraints as it has been shown to be more calming and less inflammatory. In terms of the legalities, throughout the management of the patient, the doctor should be conscious of the legal implications accompanying the management of the aggressive patient. Safeguarding both the doctor and the patient are key to managing aggressive patients. The relevant documentation must always be filled out. It's important to note that delirium is not an indication for certification as an involuntary user under the Mental Health Care Act. Patients with psychiatric disorders should be classified as involuntary healthcare users in accordance with the relevant articles in the law. Here, the family plays a very important role in terms of applying for certification. And in extreme cases, the usual certification process cannot be followed. And so emergency certification must be performed as a last resort. So in terms of documentation, so an Mental Health Care Act 17 of 2002, Form 1 must be filled in the first 24 hours of observation, and this is for emergency admission. Then Form 4 and 2 Form 5s for assisted or involuntary admission of a patient should be then used in the next 72 hours of observation. Then when mechanical means of restraint are used or a seclusion room is used, Form 48 needs to be filled in. If a patient needs to be transferred to a maximum security facility, Forms 19 and 20 need to be filled in. And in terms of apprehension and handing over by SAPS, Form 22 needs to be filled in. So in terms of the use of mechanical restraints, as I've mentioned, when medication and verbal therapies are insufficient to control the potentially violent patients, mechanical restraints are used for the protection of patients and others. And in South Africa, according to the Mental Health Care Act number 17 of 2002, the use of restraints is permissible, but subject to certain regulations. And these are the following regulations. So mechanical means of restraints may not be used under transfer of a mental health care user or within a health establishment unless pharmacological or other means of calming, physical means of restraint, or seclusion of the patient are inadequate to ensure that the user does not harm him or herself or others. Where mechanical means of restraints are required in order to administer pharmacological treatment, such means should be applied for as short a period of time as possible until the treatment has taken its effect. While the mental health care user is under restraint, he or she must be subject to observation every 30 minutes and good clinical notes must be made. Whenever mechanical means of restraint are utilized, a register must be kept for that purpose, must be signed and completed by the relevant medical practitioner. The form of mechanical means of restraint, the time period used, and the times when the mental health care user can be observed and the reason for administering such means of restraint must be, and the head of the health establishment concerned must receive a report on a daily basis that indicates all incidences involving the use of mechanical restraints. A transcript of the register must be submitted by the health establishment concerned to the review board as Form 48. And mechanical restraints must not be used as a form of punishment for the patient. And then in terms of seclusion, it's basically everything that we've mentioned already, and due to time, you will not be reading the slide. You can read it in the leisure of your own time. Okay, next slide. In terms of post-violence counseling, it is important to always remember that this is a multidisciplinary approach, and that psychologists and social workers play a very important role in post-violence counseling. So this must be done prior to discharge, and it is very important in patients with prior history of violence. It also helps patients identify the precipitating factors before it occurs, the violent behavior. It also strengthens the patient's understanding of negative consequences of further violence. It also motivates them to prevent any further violent episodes. And it also equips the patient with non-violent alternatives to deal with conflict situations. Thank you. These are our references.
Yeah, great. Yeah. You've included the case study there. If you don't mind just emailing me separately, sure. Otherwise we'll pick it out from there. But thank you very much. Well done. I think that was very comprehensive and appreciate that. Let's just get you a chance to give them some feedback. So just rate the presentation. Just in the meanwhile, I don't know if there are any other comments, questions from any of the interns or any of the registrar, the family physicians. One of the things that, I think, besides counseling the patient, is counseling the team in dealing with violence. It kind of creeps up on you, and when it occurs, it's usually because we haven't prepared for it. So I think counseling the team to look at why that erupted and what they didn't do to be aware of it. One needs to be sort of taking precautionary measures by screening patients that are potentially going to erupt in violence. So I think it's a mix of those issues. Great stuff. I think let me just wait until a few more people have given you a rating, and then we'll share that. Are there any other questions in the meanwhile? Any comments? Dr. Aki, Dr. Pekova?
Yes. Yes. Can you hear me?
Yep. Go ahead. All right.
Yeah,
I'll end the poll here.
I think this is a good presentation. However, much of it has been, kind of textbook stuff. you will find that there is a difference between how we manage patients at a tertiary care level or a hospital level and primary health care. So those are some of the key issues that the interns will have to grapple with in a clinic setup or a CHC. Neither of all those things that you listed might not be available. So you have to think through how you are going to manage this aggressive patient. So for instance, as you say, to restrain an aggressive patient, you need like 6 people. You are not going to get that in a CHC at night. A patient who has been brought by relatives, there is 1 doctor on call, probably 2 if you are lucky, and 1 nurse, and maybe 1 security. So, yeah, so for me, in terms of this, I think we need to think very carefully about the practicalities of the situation we have in our facilities and try to relate it to, the recommendations that have been given by, well-established centers and centers which are designated for managing this type of patients. The other thing also is that how easy is it to refer these type of patients to a psychiatric evaluation center? Say you are in Zola CHC and then you get this patient. So we have always had very serious issues referring psychiatric patients, say to Bara, they will tell you the bed is full and, so on and so forth. So there are a lot of issues practical issues that we grapple with at the primary healthcare level, which may not be exactly as recommended in the presentation that you have given. So you just need to be aware of this. Thank you.
Well, thanks for that, Dr. Aki. I think, the value of us going through this is to go through and see what is best practice. You need to be then using it in 2 ways. One is that you need to be seeing how, in your experience in primary care, that what is not possible, but how also people make do, how they try to manage it, keeping in mind safety for you and safety for the patient and the system. But on the other hand, it also, by going through this, gives you the opportunity to know what should be happening and to advocate for that, and to use the power you have of knowledge to say this place needs to be kitted well enough to handle these kind of situations. So I'm sure that everybody has that approach in their minds. Thanks for that reminder, Dr. Aki. Okay, let's move to the next. If there are no other questions or comments, let's move to the next presentation. And